there, my name is Dr. Kendra Saxvik. I'm a clinical pharmacy specialist. I'm a board-certified psychiatric specialist. I work at the VA, and today I'm going to be talking to you about the SAMHSA-HRSA Center for Integrated Health Solutions framework for 6 levels of collaboration and integration. So today, some of our learning objectives, we're going to define what integrated healthcare is. We're going to discuss the levels of integration. We'll also discuss the SAMHSA-HRSA framework for collaboration and integration and differentiate between the levels of integration based on the SAMHSA-HRSA framework. And we'll discuss the benefits, weaknesses, and barriers to the levels of integration. So first, let's define what collaborative care versus integrated care is. So collaborative care is typically what we think of as our standard level of care, or our standard treatment process now, where we have mental health and primary care in separated services. And while there may be some communication between them, there's not a whole lot of consistent communication, and the treatment plans are separate. Integrated care is the model where physical health and mental health are treated in the same center by the same people. And what this allows is for more encompassing of the treatment of the patient as a whole. And really this makes sense because physical health needs and mental health needs are often interlinked and affect each other greatly. So to promote moving towards an integrated care model, SAMHSA-HRSA, which is the Substance Abuse and Mental Health Systems Services Administration, and the Health Resources and Services Administration combined to form the Center for Integrated Health Solutions. This center promotes the development of integrated primary and behavioral health with the goal of better addressing the needs of those with mental health conditions regardless of the setting in which they present. It is also the first national home for information, experts, other resources, and utilizing all of these resources, they actually developed a framework to describe integrated efforts that organizations can then use to not only analyze their current practices, but see where their practice should be going and what that might look like. And that's what we're going to be talking about today. So first, let's talk about what levels of integration look like. When looking to develop this framework, SAMHSA-HRSA looked at several different studies and several different models. The first one that they looked at is one of the oldest, and it was proposed by Doherty et al. And you're going to see this come up again and again, so we're going to go through this one in a little bit more detail. This involves their description involves both this extent of occurrence of collaboration and the capacity for collaboration within the setting. They described this in the mid-90s. They began describing this integration, and as they began describing it, they decided that they needed to propose a classification system so that they can be able to describe these in better features and across settings. I want to note that they did not focus their classification on specific interactions within the clinic, but on the occurrence of collaboration and whether or not further collaboration was possible. They determined that as collaboration increases, so does the ability to adequately handle complex patients, which makes sense. With more collaboration across disciplines, there's an increased ability to tackle multiple issues at once. This description provides the foundation to tease apart the strengths and limitations of the degrees of integration within an organization. And the goal of this description was to help organizations evaluate their own clinical settings, as well as evaluate what their organizational goals were. Further, the goal was to assist in providing a framework to assist in researching outcomes and costs to help organizations strategize. Here's a chart showing these levels of integration as laid out by Doherty and colleagues. As you can see, they looked at several different areas to describe how an organization is collaborative or integrated. And again, going back to our collaborative being the more traditional model and the integrated being physical and mental health in a combined setting. They organized this from a minimal collaboration to full integration. So let's look a little bit deeper into some of these levels. If we're looking at the system level, the range is from separate systems to shared systems. Now, this includes organizational systems such as a primary care clinic that is a separate entity from a mental health clinic, but perhaps even under distant ownership. But it also includes separate medical record system, billing systems, those type of support things. The next thing they described is facilities. This is more the actual physical facilities. Are they in separate facilities? Are they co-located in the same facility? And as you can see, as we move from collaboration to integration, we moved from separate facilities to being in the same physical location, and then to being fully integrated into a shared physical space. Communications is a major determining factor in the level of collaboration to integration. In a minimally collaborative practice, there's periodic or episodic communication, generally about a specific issue regarding a patient, and it's usually written. As we move from minimal to basic collaboration, the level of communication not only becomes more regular, but the type of communication also changes. It moves from virtual or written to face-to-face communication, and then to actually collaborating routines where communication between disciplines is the norm. This can include interdisciplinary team meetings, as well as, since there is co-location, warm handoffs regarding patient care. Along with communication comes understanding and appreciation of each team member or specialist and their role in the care of the patient and within the organization. Finally, there's a level of influence that each side can exert on each other. With little or distance collaboration, there's generally limited influence of providers upon each other. As collaboration becomes more towards integration, in the middle steps, there's more of an influence of mental health upon primary care, though as integration progresses, this balance out so that they're more on equal footing as far as influence on each other goes. Another way to look at each of these different levels is these short phrases at the end of this table that kind of sum up the interactions between levels. In minimal collaboration, it's more of a, who are you? As we move to basic collaboration, it's more, I can help your clients, and this is how. Once we're moving into a shared location with collaboration on site, the mental health is more of an, I am your consultant. Once we start to become partly integrated, this moves into we're a team treating our clients. And once we become fully integrated, it's not only are we a team, but we can teach this model to others. The next system that they looked at was described by Blount, the author Blount, and he collapsed these levels of integration into three overarching categories. Coordinated care, which is behavioral services by referral at a separate location with formal information exchange, again, generally written, to co-located, where there is still a referral, but it's within the same medical center location. And finally, integrated, where mental health is part of the treatment at a medical center. And the last report that they looked at was the Milbank report. This describes 8 models of integration across a variety of settings. It integrated Doherty and colleagues plus Blount's overarching categories. This became very complex, so the details are not really going to be explored in this series, but it is important to note that it was considered by the CIHS and it did influence their design. All right, so let's look now at their proposed standard framework for collaboration and integration between mental health and primary care. The CIHS proposed 6 levels of collaboration and integration with an overarching framework of 3 main categories with 2 sublevels in each category. The purpose of this was to help organizations evaluate their current degree of integration across several levels and to determine what the next steps may be to implement or enhance integration. First, let's look at the core descriptions of each of the different levels, and later we're going to compare and contrast them a little bit. So this actually was taken directly from the CIHS's standard framework. And there's a lot of information on this slide, but we're going to kind of break it down a little bit. The first main category or overarching category is coordinated care. The key element of this category is communication between players, and this is the key level that organizations can focus on changing to be able to move into the next category. You'll see that once we look more at the levels in the next step down, that they are very similar to the framework originally proposed by Doherty and colleagues. For example, in level 1, minimal collaboration, they are in separate facilities with separate systems. The communication is rare. As we move into basic collaboration, the communications become more regular, and they begin to appreciate each other's resources, but they're still in separate facilities. The second main category is co-located care, where the key element is that providers are in physical proximity to each other. Again, this is a key element where organizations can focus to affect change. And again, looking at the levels in more detail, it's again similar to the Doherty framework. Now that they're in shared space, they may start to share systems, the communication becomes more regular, more collaborative, and they begin to have more understanding of each other and more influence upon each other in their various roles. Finally, the third category is integrated care. This is where we truly start to see practices changing models, which is the key element of this category. Not only are they co-located, but they're actively seeking solutions together, they're working together, they're communicating frequently, usually face-to-face, to work towards goals for patients. Now we've kind of described a little bit of the levels of integration. Again, it looks very similar to some of the things we talked about a little bit ago. Let's start differentiating these different levels. The first key differentiation is how clinical care is delivered. And this is more from the provider's aspect. With minimal collaboration, treatment plans are separate, the providers know nothing or a limited amount of each other's treatment plan. As collaboration increases, so does the amount of information on treatment plans that is shared between providers. Without co-location, sharing these treatment plans is difficult. Once an organization moves to a co-located level, the information sharing on the clinical plans and patient progression improves, though it is still formal and generally not complete information sharing until a level of integration is adapted. As we move into the integrated model, there is a more consistent approach to clinical treatment. This includes a more systematic approach using screening tools that both sides agree upon and are comfortable with, and a combined treatment plan. Eventually, with full integration, the treatment plan is developed with all the team members, both primary care and mental health, as well as any ancillary services such as nursing, social work, things like that. This allows for the most effective clinical decision as there is input from multiple disciplines and each can give their own perspective on the patient to further develop patient-specific treatments that are evidence-based and will meet the goals of the patients and the providers. While the first differentiator focuses on how these models function for providers, the second differentiator focuses on the patient perspective and the differences that the patient will experience as we move from a collaborative to an integrated model. In the coordinated category, patients must navigate two separate systems. Their needs are treated separately. As we move towards minimal collaborations, patients are often left on their own to figure out the system, which they may or may not be successful in. With more collaboration, there is some improvement, but the patient is still left with many barriers, not the least of which is navigating our very complicated healthcare systems, multiple offices, billing, those type of things. As care becomes co-located, then we can start to see an improved patient experience. There's more successful referrals with less barriers for patients to negotiate. As care then moves into integrated model, there's more of a one-stop shop feel for patients, which they respond positively to, as well as the feeling that all team members are on the same page, as is more of a seamless response amongst the providers. The third differentiator focuses now on how these models function for the organization. As has been the trend with the other differentiators, as we move from left to right across these columns, we move from little coordination and limited buy-in to more fully involved providers. I really want to note that in order to accomplish this, there must be support from within the organization leadership. Having leader support improves provider buy-in, which is essential to full integrated model. Of course, organizational support is often tightly interwoven with business support, which is our last differentiator. And we see again that in collaborative models, there is a separation of the business aspects such as billing. As we move towards integration, we'll start to see some sharing of the fiscal costs, but also possible gains such as grants, splitting office overhead costs, and being able to maximize billing. Now that we've kind of described how these categories and levels are work and how they're viewed and how they can be viewed by various stakeholders, let's talk about the advantages and the weaknesses of each of these levels. Some advantages of the coordinated care model include autonomy of the practices and the providers, as well as this has been the common practice, so it's familiar for patients and providers, it's comfortable for them. It also maintains the current basic operational structures, so minimal change is necessary, either in a provider or an organizational level. However, the services provided may overlap or be in direct opposition to each other. For example, prescribing of medications that may interact between the primary care provider and the psychiatrist. In addition, there's a risk that important aspects of patient care may be going unaddressed as there is limited communication between the sites. As we move into co-location, this allows for more direct interaction and flow of information, which improves patient care outcomes. This allows for improved communication regarding patients, but also allows the professions involved to have a better idea of what each can contribute to the care of the patient. Of course, there's still barriers to being co-located, and simply being in the same physical space is not sufficient to automatically foster those benefits. Relationships between providers do take effort on both sides, and there may be some conflict amongst agendas without good communication as you start to integrate and co-locate. Once again, organizational support is key to making that effective. Finally, we move into integrated care. There are some significant advantages to this model. The high level of communication results in more responsive patient care, which increases adherence to treatment plan, which also means lower cost overall, as non-adherence is a major cause for increased healthcare expenditures. Providers have the chance to truly treat the patient as a whole, which increases both patient and provider satisfaction. We're trained to treat the patient as a whole, but we are often limited by our systems in being able to do that. To achieve this does involve a significant investment, particularly in time, on all of those involved, which is a weakness of the model, as well as that it is a major change to practice. And this can be difficult for providers to go along with. Finally, there's not a lot of practices out there with the highest levels of integration, so being able to truly talk about outcomes is difficult as there's not a lot of data out there yet. So to wrap things up, we talked about some drawbacks and benefits to the various levels of integration. The SAMHSA-HRSA Center for Integrated Health Solution provides an excellent framework and resources for being able to move organizations from collaborative care towards integrated care. You can use this. Organizations can use this to determine their current level of integration as well as where they want to go, and the resources offered through SAMHSA-HRSA demonstrate benefits at the next levels of integration, which can be used to increase provider buy-in as well as administrative buy-in. Guys, here's some references. Thanks for taking time today.
Hi everyone, and thank you so much for being here today. Today we're going to be discussing the SAMHSA-HRSA Integrated Health Solutions Framework for Collaboration and Integration. So before we get started on our discussion, I was hoping to just go through all of our speakers today and get a little introduction from each of you, and please tell our audience a little bit about where you work.
Sure. I'm Dr. Kendra Saxvik. I'm a clinical pharmacy specialist. I specialize in mental health. I currently work over in specialty mental health care at the VA here in Corpus Christi.
And I'm Dr. Pam Green. I'm a psychiatric mental health nurse, and I now teach here at Texas A&M Corpus Christi in the College of Nursing and Health Sciences.
I'm Kristen Hines. I'm an LPC, and I work in primary care mental health integration at the VA outpatient clinic here in Corpus.
Thank you all for being here today. So I kind of wanted to start off in talking about this framework, just kind of what some of the systemic opportunities that you guys see. We can start from an administrative level, but what kind of opportunities do you see with a framework such as this?
I think the framework really provides from the system level, a great way to think about where your system is and what the next step is to get to the next level on a continuum moving towards fully integrated care. It gives a lot of examples of where each system might be with regards to communication and other aspects, but also what the next step looks like so that administrators can start to kind of plan what staff do we need to be able to move this? What physical locations do we need? What services are we going to have to be able to move towards this next level? And I think that's probably the biggest benefit of having this framework all laid out from the systemic level and the administrative level.
Absolutely.
And I would probably add to that as you're speaking, and with existing staff, what training will they need to make this shift in thinking for this, a different way of thinking and integrating care?
Absolutely.
Yeah, making sure that providers are on board with it and understand what this is going to look like and how it might change their job a little bit, but really in the long run benefit everybody, both providers, administration, and patients altogether.
I agree.
Absolutely. And from a supervision level, what do you guys think some of the opportunities, so we've talked about a little bit from a systemic level, but what about from a supervision practitioner perspective? What are some of the opportunities from a framework such as this?
I think one of the great ways that they broke it down is this is what the next level looks like, but here are the benefits of that level. Because as a practitioner, you get entrenched in what you're doing every day. And when someone comes along and says, okay, well, now I need you to also do this, knowing, okay, what exactly does this look like? And what exactly is this going to do for my patients, for me as a practitioner? How is this going to benefit me? Why should I do these things? And the framework provides some of that benefit. For example, moving from co-located to more integrated. What's the benefit of that? Well, my patient gets more full care around the whole patient. But also, I have a little bit of my burden taken off of my plate as a primary care provider, because I now have somebody who I can turn to help with my patient who's not taking their medications and I can't figure out why. As a more an example of that.
I think, though, within the systems, it really requires then a rethinking of even the actual setup of office space and that sort of thing. And that can be hard because that can create some constraints. But I think it can also draw on the creativity to figure out how to use existing space in ways that are different than they were originally built for. Just to help that happen. Because it's like, we'll say, well, but we have this here and you're over there. How do you shift that? Again, I think a lot of times if you open it up as an opportunity for creativity, it can work well to not keep people so siloed and separate.
Yes.
Yeah, it creates better opportunity for communication as well when everybody's in the same location, so they're not emailing or trying to catch somebody or calling when they have a minute, but being right there with each other is just it's such a better opportunity for communicating right then and there about the patient needs.
Right. And as a supervisor, being able to demonstrate that to the people underneath you and say, well, remember last week when it was so hard to get a hold of this person when you really needed these test results? Well, if they were here, we could have very easily been able to do that because it's in the same electronic medical records, or it's just down the hall. You could have that conversation with them. And so being able to point out the benefits can really get more practitioner buy-in.
Absolutely, just that ease of access as a whole.
Yes, and I think at the supervision level, having the supervisors from each different discipline modeling that communication and collaboration is what's going to be really important for it to come down to the practitioners there.
And I agree, and I've seen systems where there's not that much supervision support and it becomes difficult on the practitioner level to be able to implement. Because if your supervisor doesn't emphasize it, why are you going to emphasize it? And I've been in models where the integration was not successful at first, partly because of that. Because one of the supervisors over one portion, the mental health portion, was very, very on board with it. But on the primary care portion, that wasn't a priority. And so then it made it a little bit more difficult on the ground level. But once that supervisor was a little bit more on board, and I think honestly something like this framework to show what that looks like would have been helpful at the time, it got drastically different. And it became very rapidly an integrated model. Very rapidly, the primary care provider started utilizing the services and taking advantage of the assistance that they had.
Absolutely. So really from an administrative and a supervision perspective, really getting that buy-in from everybody that you have incorporated in something like this is very beneficial.
Yes.
And I think administratively, you're also in the end going to get the most out of people. And I don't mean that in a bad way, but you really get all the skills from everyone at the best level possible. And it's a model that's very efficient when it comes down to it, and can be cost effective, because I know that bottom line dollars and cents matter. And so that piece is great. And then I think from the clinician standpoint, when I looked at the slides and saw that bottom right-hand corner where everything comes together, we're learning from each other. It's like, how cool is that?
Absolutely. One of the examples of moving into that was when I worked in primary care mental health at a system in another state. Being able actually, once it was fully integrated, to even move outside of primary care into specialty care, that helped. They were able to start a CPAP clinic to help people get more comfortable using their CPAP within primary care mental health, which meant their blood pressure went down, which meant that they didn't need to be coming in for exacerbations for COPD because they were breathing at night. All of those different types of things. And so the benefits greatly expanded once you get into that bottom right-hand corner and full integration.
Yeah, there's definitely some growing pains once it gets started. People become almost territorial about their space, and we don't need you in this area or whatever. This is primary care only, or you're using my office and I need to see my patients in there. But I think ultimately when you see benefits like that, where the primary care providers or really anybody can give some of that responsibility to someone else who maybe has a little bit more experience or expertise in it, they're going to see the benefits of it, and it's going to really become a much better working environment for everybody.
Absolutely. And so with all of that being said, when we're looking at our current geographic location here in South Texas, how viable do you think something like this is, or how viable has it been up to this point in the settings that you've been working in? Is it realistic?
I think it's realistic, but I think it needs to be a long-term goal. And I don't think that you can skip steps within the framework, because most of our systems around here are still in the collaborative, at best, levels,
Sure.
And moving towards more co-located to integrative care. I don't believe that you'll be successful in this area moving just from collaborative straight to integrative. I think that there will be a lot more growing pains, and moving through the different areas gives time for the culture of the systems to shift.
Absolutely.
But I do like what you said. It is step by step, so that it's not overwhelming, and so that you have a chance to work out the bumps at each level before trying to bite off more than you can chew and make it a disaster kind of thing. I worked in a setting that was kind of flipped. It was really a mental health setting, and we ended up integrating and co-locating and then really becoming truly integrated. And for our patients, we had an internist, a family nurse practitioner, and a PA, along with a chaplain, a psychologist, psychiatrist, and the nursing staff and the rehab staff and everybody. And so what we saw over time, because we didn't have all of that initially, was how in a 45-minute time frame, how many patients we could cover that were problematic, and really, and we brought the patients in as well, and it was transformative for the care of those individuals.
Yeah, absolutely. And you bring up a really good point. A patient can come to one building and see all of these people at once. So we're creating better healthcare system by integrating with all of this too.
Do you guys believe, with all of that being said, that there is any stigma associated with a framework such as this, or what kind of barriers might you encounter when looking at stigma of healthcare, of mental health care?
There definitely is, and traditionally medicine and mental health have been separate. That's kind of the way that we were all trained. That's kind of the way that it's been, even, at a patient level, but also at a systemic level, is that these are separate services. They don't have anything to do with each other. And anytime you have change, that's going to come up, is that, well, we didn't need it to be together before. Why do we need to be together now? Mental health isn't what I do. That's something else, and that's not a problem that I address. That's not important. And getting more, and honestly, as you move through the levels of integration, you find that providers and administrators start to realize, no, they really are tied together. But as far as in our area, that stigma, it is still there. It is still hard for some providers to realize and recognize that all of these things are part of the patient as a whole. And I think that's partly changing within our medical community, but it takes time to really change that culture.
But we can challenge it in a way that's really productive. And I'll use an example. This semester on campus, one of our student interns was looking at the campus map. And it's very interesting because the student health center is listed as the health center and the name of the building. There's no way that you could tell on the map where the university counseling center is. And so this intern who was passionate about mental health care for his colleagues and fellow students took it upon himself with a little guidance to go to the university structure of how to get that changed, how to just get the signage so that people know. And it shouldn't be a secret and just challenging that it also shouldn't be something that we're ashamed of to walk into the counseling center. So that's been changed now, and this summer the actual physical signs on campus will be changed. And it sounds like kind of a little thing, but symbolically it's been very important for students to know how to find the care that they need.
Mm-hmm.
Absolutely.
Yeah, and Dr. Saxvik, you make a really good point too about stigma being a thing with patients, but also with professionals. You know, if you go see your primary care physician and they say like, oh, well, you can go see mental health, and they kind of brush it off as not important, the patient might not feel it's important or might feel there is a stigma there too. Whereas if you can get everybody on board saying that this is a really good collaborative approach, we need to be addressing all of these things collectively, I think that you're going to get more buy-in from the patient level too.
Absolutely. I absolutely agree with that. It matters what your doctor says. It matters how your doctor says it. And we know about this from when we're talking about diagnoses and how to approach treatment options and things like that. But we really need to do it to our colleagues as well.
Mm-hmm. And I think as you move through those stages of integration, that allows for you to teach other professionals about what you do. What's your scope of practice? How can you help? You know, maybe there are different ways your practice can be utilized to help them out. And I think as you go through those steps to full integration, that's when you get the opportunity to teach other people about your different disciplines.
Absolutely. Well, thank you guys so much for being here today, and thank you for your input.